Can we see the screen now?
Yes, now we can. Yes, now we can see it. Yes.
Yeah. So some of the most wonderful children are the ones who do not fit into the boxes, rightly told by Taurus Amos. I would be starting the presentation by introducing these kids who are referred to as Kininaro Kodomo in in Japan. They were termed so in Japan at around 2012. And UAE, these children are known as children of determination or the people of determination. And as the rest of the world knows them, they are the children of special needs children. And these terminologies from the Western world or the American Academy of Pediatric Dentistry, as well as Center to Disease Control, was termed in 2004. Now, what we understand is with the terminologies, we see the effort that there is an effort of humanization, as well as removing any stigma from the neurodiverse children or differently abled children. So we understand that words have power, they can crush or they can heal you. And likewise, the language which we use also has an impact. So the language can impact a person or shape the behavior as well. So we understand the importance of language as well. So I would like to introduce how people first language was advocated by a lot of people, wherein the people with neurodiverse conditions were referred to as people first, and then thereafter mentioned about their clinical diagnosis, unlike a deaf person or a blind person. But then there's a lot of debate. But what is not debatable is a person, when asked, would want to be referred to as named by their own parent. So that is not debatable, and that would be the way to go forward. This is introducing myself, Dr. Ghousia. All I would want to say is I had taken some information from NIMHANS, that is the Neurological Institute of Mental Health Sciences in Bangalore, and also trained myself in sensory informed pediatric dentistry, and underwent an early intervention program with the therapist. So that is why I'm here to share some of my learned information with the graduate students here. And why am I here? Of course, to help you all understand what actually is neurodiversity and how is the behavior different in these neurodiverse children. So when we hopefully end up this session, we should be able to understand that behavior can be misleading, and we would want to see something beyond behavior, that is the sensory disability. And we would want to know the differences between behaviorally challenged as well as sensory challenged children. And some more details on introduction of the oral cavity is the sensory rich zone of the human body, and our dental operatory system is a sensory rich environment. So we would basically probably hope to learn some striking of the balance. It is tough, but we would try to aim at striking a balance and introducing a sensory smart oral health care for these children. So as told by Dr. Panke, we never see a tooth walk into our dental operatory. We always see the person who is having these teeth. So we have to understand the person we are treating. Like they always say, know who you're treating. So we are going in detail to understand the neurodiverse conditions. So what we see here in this picture is the animal kingdom with four-legged animals, creatures crawling, flying, swimming, and also the creatures with two legs. And they make the animal kingdom diverse and beautiful. Likewise, in the human community or the population, we have all sorts of people with different genders, races, color, and also with some of the people who would want some aids in their mobility. So then we have some diversity even in our brains. Though anatomically we all look same, we might have a different way of perceiving things, as well as we might have a different way of reacting to things. So these diversities actually in a whole make this world a beautiful place. So we should accept that differences are not defects, but they are something to be coexisting with. So moving on to the model of disability, which was given by Olkin in 2002. So when we see this lady trying to aim to climb the stairs, we have two different thoughts processes. The medical model of disability, wherein it is basically aiming the problem at the impairment, that because of the lady's impairment she cannot utilize the staircase. Whereas the social model of disability is basically mentioning about the environment, that we are not sensitized and environment to include these individuals. So this is the medical model of disability, wherein the whole problem is focused on the the patient, which was later challenged upon. So we were this model basically searches every possible place to blame the person who is affected. So this model was challenged by a social model of disability, wherein we try to sensitize the people and would want an inclusive environment, which is otherwise excluding these people who cannot, always thinking of the neurotypical. So this is a physical model of the physical illnesses which we see. So what about the neurodiverse or the invisible illnesses? So the model which we would want to talk about is NeuroAffirmative Model. And since the topic is this, I would be focusing more on this. So in 2018, there was a study which came out from the University of Zurich, which says that the human brain is as diverse as human fingerprint. Now, this is probably because maybe the neocortex as well as the fingerprints, form together in utero. So neocortex is very much important for our cognitive abilities, emotions, development of language. Also, I would want you all to take attention to the neurodiverse conditions. So what are the neurodiverse conditions? So all the developmental disorders, global developmental delays, autism spectrum disorder, sensory integration disorder is though not independent right now diagnosis because of the DCM manual not being introducing it. So the DCM manual, the latest fifth edition has come only in 2013. The latest one is yet to come, hoping that SPD or the sensory integration disorder gets an independent identity there. And what is another surprising fact is that even the gifted children are included in your neurodiverse condition. So after having to understand that, we have to understand that brains of two types, the typical types, which we often see, and the whole world is made up of the regular norms, or the neurotypical people understand each other very well. Likewise, the people who have some neurodiversities or different way of thinking understand each other very well. So there is a two-way problem, that there is mismatch communication. The neurotypical may not understand or perceive a neurodiverse brain or the way of thinking or behaving, and vice versa. So this is wherein you have a double empathy problem, as mentioned by Damian Milton. So what happens here is the person with neurotypical might enjoy taking bath, but the neurodiverse person may have problem with the temperature of the water, the dripping of the water, and likewise. So there are a lot of problems a neurodiverse person sees a world with, not like a neurotypical person. So this is a statement which I would like to emphasize before we move on ahead. To understand further, grant me the dignity of meeting of my own terms. Recognize that we are equally alien to each other, that my ways of being are not merely damaged version of yours. So this is the understanding we should be dealing with whenever we see a neurodiverse person or a child. So coming on to the oral health behavior or the disease which is most affected and common disease is in the global health population, it is 34% of the global health, as mentioned by the Lancet. And coming to the neurodiverse, of course, it will be more. And most of these people do not access the oral health care because main reason could be, the provider, there are barriers like the providers are not aware of it, and the communication barrier is there. And also most of the healthcare professionals are not willing or not well equipped or trained to deal with these neurodiverse or disabled persons. So I'm glad that Oman Dental College is taking an effort to expose their undergraduate students to a very sensitive issue which we lacked in our education days. So moving ahead, I would recommend that disability service should not be segregated from health services. They have to merge as a team and move ahead so that, all people are included in the environment. Now, this is what we see when a child is crying. We just see the outward expressive behavior and we can always mislead it as a temper tantrum being thrown. So what lies below the iceberg is basically the innate emotions, the anger, the sadness, there is self-regulation. There's a problem with self-regulation. Most of the children have problem, even the neurotypical children have problem with regulating their emotions. But coming to neurodiverse, they do have it for longer. They won't be they do not learn to regulate their emotions very easily. So that is where they need our help or interventions. So like a typical example, as per the dental scenario, when we see what you see in a dental operator is a child biting for no reason, but we do not see the underlying causes. So we would just want to put a discipline or stop the behavior or give a punitive punishment for the biting, but we would not see what are the other causes underlying. Probably the child is hungry, not wanting to share or be with the people, and also there could be teething. So we should understand and try to segregate, is it just the behavior which we are seeing outwardly, or there is some deep underlying issues like sensory issues. So get curious, go beyond the observable behavior so that we understand and follow the norms. So what we have learned in our curriculum, at least till date, is managing or behaviorally supporting now or guiding these children of behaviorally challenged children. So a few of the techniques which we all are versed with are basic versus the advanced techniques, pharmacological versus non-pharmacological, tell, show, do. So and then we follow this spectrum. I at a point in my career, when I was practicing, I did understand that my techniques were going very well, but there was a point when I was not very successful. How do I tell, show, do when the child is not looking at me, not making an eye contact? Looking at me is a far thing. The child is not even having an eye contact with the parent. The child doesn't respond to the name calling by the parent, and I, being a stranger, would not come into the picture. So there I was failing to understand, and I was not very comfortable going for the pharmacological ways of managing. So I had to explore this situation, and that is when I landed up into different institutions to understand the pediatric psychiatry. And what I understand is a child whose behavior pushes you away is basically a connection seeking behavior, not an attention seeking behavior. So moving on to what is oral health behavior. Oral health behavior comprises of not just the eating habits or brushing hygiene, but also the surroundings, the parenting styles, and a lot of other things. And hence there is a lot of efforts, especially before the pandemic. There were a lot of studies undergoing wherein they wanted to change the oral health behavior. They wanted to integrate, remove the disparities of the healthcare professionals, make them more logical and reasoning and thinking. So we have something called as COM-B model, that is the with the inner behavior wheel circle. So behavior basically comprises of capability, motivation, and opportunity. So each individual should be assessed like that, and thereby understand why their behavior is accordingly. So the underlying behaviors have to be reasoned out or logically thought about why it is so. So there was a consensus meeting by the clinicians, researchers, educators, teachers. So we understand that child is not brought up just in a single home. We do have an environment like a school, the college, the school and the surroundings. So we have to include all these stakeholders for the child upbringing and turn. So in this effort, the pediatric dentistry of King's London and Manchester introduced something called as behavior change in dentistry, and thereby the following year came beside group, that is behavior support in dentistry, wherein there was a decision to come into common consensus. Even the therapists or teachers use the same techniques to manage a child, or to behaviorally support a child, but there are different terminologies. For example, graded approach, we use desensitization, acclimatization, and so on and so forth. So this is I think this is the position paper which just came out before the pandemic. And so we move on further to segregate the behavior. So I'm going back to the pediatric psychiatry, that is the Erickson's theory as well as the Paget's theory of sensory motor. So we always focused on the behaviors, but we forgot the sensory part in these theories when we learn, which I learned from the institution which I was practicing. So behavior-based children basically are driven by a want or a goal, and they want something, and these child basically pay attention. They need an audience seeking, and once the child gets what they want, their behavior abruptly stops within a span of 5 minutes. There is no autonomic nervous system signs like flight, fight, and fear. And unlike the sensory-based behaviors, whereas it is driven by a reaction to some trigger factor. They have a sensory trigger factor, and there is an overload or overwhelming situation or a lot of sensory input stimuli for this child. They do not look at attention, and they do not even after the audience is gone, they continue to behave in a certain way. They do not have a goal, and it is completely associated with autonomic nervous system's 3 F's, that is flight, flight, and fear. So after the trigger is removed, to come to normalcy, they take about 45 minutes to 1 hour. Uh, and so I'm narrowing down the topic to the sensory challenge. I'm rushing because we have limited time, as told by Dr. Polixini. So sensory challenges and oral health behavior, we do understand the neurodiverse kids in common have sensory issues pertaining to the oral health. So we also 93% of the autism spectrum children display the sensory processing disorder. 40 to 60 people of Down syndrome, cerebral palsy, and our ADHD, that is attention deficit hyperactivity disorder, do have sensory issues. And not to forget the neurotypical children, at least 15% of them do express sensory challenge. And as you see this slide, most of the people may be comfortable and some may not be comfortable with the visual stimuli which was put on that slide. So that was to show that each of us perceive things in a different way, and we do have a unique sensory profile for each other. So this is a morning scene in most of the houses wherein the child is having an aversive condition or the aversive reaction to the basic toothbrushing. This is the same child who would have problem while defecation, taking bath, because of the fear of defecation. The processes of defecation also would be painful, even the feeding disorders. So we need to understand the daily healthcare, daily activity, living procedures, and self-care skills are very difficult in children who have the sensory processing disorders. Let's coming to understand what is sensory system. So our senses are 8 in number. So five of which we all know, and three are innate, which are inside. That is the vestibular, which helps in balancing our system. Proprioception is the pressure. Interoception is basically on the heartbeat, blood pressure, stretch reflexes of our urinary bladder. So these are hidden senses, and the rest of the visuals, so visual, auditory, gustatory, smell, these I hope you people are aware of. And these are starting in utero itself, and one of the first sensory system which develops in utero as early as 5th week is the vestibular. That is the balancing. The fetus starts balancing in the amniotic fluid. So that's the first sense, followed by the tactility, that is the touch. And there is inside the womb, the skin, human skin, is allowing the direct sunlight. So it's analogous to a room with curtains pulled. And also the smell, hearing are intervened, smell and taste are intervened, because 90% of taste is from the smell. And the child can hear and learn inside the womb. So sensory system is that important, and it starts growing. The child starts interacting even before coming out of the womb with the environment. Now coming down to the sensory challenged child, so there are two types. One is the sensory impairment, where there is a direct deficit with the organ system, basically the eyes, ears, or there can be dual system, that is the deaf and blind, or multisensory impairment. So another one is the processing disorder. So the senses are, we have the organ system in place, but the signals which reach to the brain and the brain registering it and executing it is where there is an error. So modulation of sensory, wherein the child is over responsive or under responsive or wanting more. Sensory discrimination, the child is not able to segregate or discriminate between lot of the 8 senses. And on the movement, that is the vestibular one. So just a note on sensory impairment. So this is a hearing aid, and the child with blind glasses, and this is a dual. So we do recollect Helen Keller, wherein she uses the todoma, wherein she touches the vocal cord lips, and so she uses her touch receptors, the finger touch receptors, to combat what is deficit in her, and then she progresses in her life. So these are the children whom we'll have to modify our techniques while managing them in the dental operatory with the braille, or interpreter, language interpreter, and so on. So let's move on to what is actually sensory processing difficulties, how they actually look. So the system with multiple plugs may crash, because so much of information is given to the system at one point. So the same thing happens to an individual wherein multiple stimuli is given from all sides. They may be normal seeming to most of the people in the world, but the particular child in question, the brain cannot take too much of it. So you must have seen the motion sickness, the air sickness. So these people are sensitive to movement, sensitive to even vision, and likewise. So these people have some processing errors, and that is where the sensory processing difficulties may exist. Now here the child finds it difficult. It needs an adult's help to separate itself from the sensory trigger, rather than disciplining this child, not understanding the reason for the certain behavior. So it is not the right time to discipline the child when the child is undergoing a sensory storm. So again, understanding this chart, we do see a cascading effect. The foundation block of our behavior, the cognitive abilities, the higher reasoning effects, what we see ultimately is basically based on the building block of sensory stimuli, which initiates your motor receptors, thereby the social behavior, and likewise. So you see in the chart, sensory symptoms. So we need a good sensory input for a good behavior to come out. So ideal sensory input leads us to an ideal behavior output. So coming back to oral cavity, why are we talking about sensory processing system, and why is it so related to us dentists? Because we're dealing with the oral cavity day in and out. So to understand more in detail that SPD's sensory processing disorder is more important for dentists in concern, the oral cavity is the most organizing part of our body. So the first motor combination or the synchrony, which is seen in a child even in utero, the suck swallow breathing, and even postnatally. So the child basically, touches the mother's breast. So this is an uh, related to this basic synchrony is correlated to suck swallow reflex along paired with rooting reflex. Rooting reflex is where the child opens the mouth turning towards the corner of where once the corner of the mouth is stimulated. So this is a very basic and integral part, and this takes maturity only by the end of the term, that is by 27th to 37th week of gestation. So any preemie before that is born, this is an immature reflex, and that is where your feeding disorders, food pocketing, pouching happens. Now this becomes very important in our dental home concept and anticipatory guidance when we are talking to our parents. And so initiation of stimuli at very early age, I mean in the infancy, in the preemie children, should be initiated very fast with the concerned lactation specialist and the feeding specialists. Now coming back to the next slide is the cruciality of oromotor skills linked to the fine motor skills. So we see the brain here, which is having motor cortex pairing with the somatosensory cortex, and they are the great team. And beside that is a representation of the brain, and you have homunculi. That is how the brain sees us. The representation of our human senses are in a way of homunculus, which is a little man. So when you see the hands are bigger, the mouth tongue is bigger, which shows that maximum sensory receptors are at the mouth tongue lips area, and next is in the hands. Then you see the brain representation, hand and mouth are together. So they are so closely interconnected. This can be illustrated when you close your eyes and try to lift the bottle uh, filled with water, and then you open, and there's a lot of difference. The sensory stimulation, what with the opening eyes and closing eyes, you all can practice once the session is over. And that again emphasizes our Paget's theory of sensory motor. So fine motor skills of the hands are very important for us because of the oral hygiene techniques, or the toothbrushing exercise, which is self-help care skill we will be inculcating. Most of the neurodiverse kids do not have these skills very well developed. So these are the grasping skills later maturing to the pincer grasp by the 9th month of post birth. So the child independently can brush themselves by the 8 years of age, when the child is able to pull the zip or tie the laces. Till then the child might need assistance. So you have kinetics of toothbrushing, which can be kinetics of toothbrushing basically is the wrist joint and flexion of the arms. So that is dependent on your integration, the sensory integration. Coming back to the oral, our dental department. So how are we managing these neurodiverse kids? So we did understand these neurodiverse kids have, the behavioral issues which have underlying causes. So these children exhibit few oral challenges which are very important to be addressed in dental operatory. Another thing is our dental operatory itself has multiple sensory stimuli. So we need to address these two issues in order to successfully render treatment to these children. So basically, I would be advocating and standing up for these kids in this presentation, so that these kids deserve, get their deserving oral health and health equity rights. So coming down to oral sensory disorder, wherein oral hypersensitivity, these children have aversion or picky. They have a fear of food eating, and anything you do in their mouth, they, any flavor, fluoride application, they might hyperreact and may not be cooperative. As opposed to the children who are hyposensitive, oral numbness, these are the chronic children with food pocketing and pouching, which would be common visitors to our dental clinic, and they may be relatively cooperative. uh, Food movement doesn't happen in the mouth, and that is why early childhood caries happen in these children at very early age. And there's a note on global hyposensitivity. When we see oral suck swallow reflex synchrony, I did forget to mention about the hyoid reflex. Hyoid bone stabilizes your posture. So if that is not stabilized or that is not addressed when it stays immature, then the child as a whole is globally hyposensitive and sits like a slouching position or an arch position. So he might need an intervention from your occupational therapist with stretch sensory socks. And these children are compensating for their sensory vacuums by bruxism and tooth grinding. So there is a sensory vacuum created between your vestibular and your chewing mechanism, and the bruxism is similarly common in children with auditory deficit, or even hearing auditory and vision deficit. So they try to compensate for the sensory vacuum by teeth grinding. So this is a very common one for which they might visit to dental clinic. Now, oral automatism is basically in association with Babkin palmo-mental reflex. So once the palms are instigated, the child opens the mouth. So once this is resolved, you don't see stimming. But if this continues, this reflex continues, is when you see the tremors or tongue activities in children, and they are self-stimulatory, just like neurodiverse kids are regulating themselves by swinging left, right, hand flapping, vocal stimming, like making sounds. So they do oral stimming, and this can be sometimes mimicking toothache, because parents might come that child is completely poking, and then when we remote, he's trying to cry. So they might confuse the oral stimming with the mimicking toothache. So this eventually may lead to something called as this may lead to stereotypic deleterious oral habits or repetitive body-focused behaviors. They try to seek a sensation. They try to, hurt themselves, like cheek biting, lip biting. So at the dental operatory, what we used to do, we have always been doing is giving a punitive, habit breakers, but we do not know the underlying cause. We need to check the adenoids. We need to check any sensory issues. Then the whole overall treatment of this condition can be resolved. So a regular dental clinic, this is a regular dental clinic, which is a sensory rich environment, which has bombardment of lights, airways, three-way suction, compressor sound, your handpiece sounds, and there are so many lights, so many operatory people in the environment. So these are the stimuli we need to address, and how do we address them is what we would, what are the difficulties we would see. The addressing of the oral issues and the dental operatory issues will be dealt in a few minutes. So first we give an emotional chart and ask them how they feel in the regular dental clinic. Okay, then we check the oral dexterity of the child. This exercise can be done between 3 to 6 years, wherein this is a score evaluation, and a score with 5, wherein the child with 10 ml of water can inflate the cheeks, utilizing buccinator as well as orbicularis oris muscle, inflate symmetrically and asymmetrically, and then spit it out. If the child is not able to do so, then the child exhibits a poor oral function, and that instigates me to take a short sensory profile. Now, this short sensory profile, if you're trained, you can take at the chair side. Otherwise, you would want an occupational therapist in your operatory. If you're sharing a hospital-based dentistry practice, you would have a team. If you're practicing a special needs dental team, you would have an occupational therapist around. So you would want the occupational therapist to check the senses of these children. So child sensory profile can be as early as 0 to 6 months. The one which I've displayed on this is the common one, that is the short sensory profile, commonly used for 3 to 6 years of children. So tactility, I would just read out like, withdraws from splashing water. So how frequently and how always, 100%, 75%, 25%. So likewise, we have different, senses questionnaire. So this questionnaire is given to the caregiver or the parent. The score is taken, and if the score falls below, somewhere above 190, then we do not need any intervention or sensory integration for this child. But if it is falling below 50 or even 38, then there is a serious problem with sensory integration with the child, and likewise assistance from the occupational therapist is advised. So each of us have a sensory profile. Me, you, all of us will have a sensory profile, but that doesn't make us any defective. So this is a sensory bell curve. So the curve shows same as others, probably less than others. How do we perceive the world around? And definitely less than others. So the people who fall definitely less than others might need help. And likewise, you see, the breakdown of this sensory curve will let you know if the child is, a seeker. For example, if the child is a seeker, he watches everyone moving in the dental operatory, or if he's an avoider, he would have strong emotional outburst when he's unable to complete a task or open a mouth or follow instructions. So we would definitely need a help of occupational therapists if we are not trained dentists with the psychiatry and some of the rehabilitation procedures. So this is our sensory tree. Each of us do have this, and if we do not feed our roots, that is the tactility, vestibular, and proprioception, we is unnecessarily working on the leaves. That is, we are not stabilizing or integrating the system which is actually to be worked upon. So that is, this is a slide which shows the emphasis of the pediatric interactions with your developmental pediatricians, with the neonatologist, with the lactation specialist, with the feeding persons. So all of them, and most importantly, the occupational therapists who are specialized with oral placement therapy and the oromotor exercises come in very handy when we are practicing special needs dentistry. So we are most dependent on the occupational therapists because they are the ones who help the child to understand the daily activity living. And also we do need special speech language pathologists to identify tongue ties, to help them increase the speech lateral movements of tongue. And likewise, of course, the behavioral therapists all come into action. And we do have to have a sync and understanding in which school the child is going. If the child is Montessori based formal education, so this helps us understand the child's uh, developmental pattern, whether the child is a nature curer or he's going a disciplinary formal education. So this was introduced in 2021 by Canadian Dental Association, that is patient-guided sensory integration. So what they emphasize, and which I would also endorse, is that your behavior shaping in the dental operatory should be customized, tailored to every child. To every child, once you assess the child with the more oral dexterity, with the sensory profile. So likewise, your behavior shaping techniques can be implemented or emphasized upon, and to realize which sensory trigger should be minused or which should be exaggerated. So we cannot use all size doesn't fit all. So each child needs to be tapered down, and it does take a lot of time. So these are the different kind of shaping techniques which we would mention further. So external stabilization, that is how we are the child-led or child-centric sensory integration is happening. Internal stabilization is basically again at home, parents can do and a dentist can do inside the oral cavity by desensitization program, providing some sensory diet to the oral cavity. External stabilization is of course your dental operatory, the environment. So this is how we are going to guide our child or integrate our child to accept the treatment. So we should understand that we nurture resilience when we move from behavior management to emotional co-regulation. So we need to work on something called as emotional co-regulation rather than our conventional behavior management techniques. Coming to the internal stabilization, so oral stabilization happens by skill building sensory wise and motor wise, and this can be implemented by the activities or by certain equipments. So I emphasize, when we are seeing children, infants in dental home, or even if it's a hospital setup and you're asked to give a guidance to a to be parents, it's better that you educate these parents so that there are no future early intervention cannot be less spoken about. Early intervention can regulate the whole child, and then the neurodiverse condition can be reduced. So oral sensory motor stimulation. So this is these are the strokes which a parent has to be taught. We always see parents giving the body massage, but we do not tell them that there is something called a spatial massage. The touch sensation, the haptic response should be stimulated in the child, especially if the child is a preemie, wherein the suck swallow synchrony is prematurely stopped, or without maturation the child is already interacting with the environment. Also intraorally we have to clean as well when we are massaging and giving the sensory stimulation of proprioception as well as tactility. We use the xylitol swabs so that furthermore the dental decays do not happen. So these has to be properly educated to the parents, and this is one of the first bond the child starts developing with the parent. Parent interaction is very important at this stage because touch is one of the first languages child understands. So this is another technique. These techniques are being mentioned here so that a dentist in concern, when referring the child to the occupational therapist, knows what to prescribe, what to seek and ask for from the concerned occupational therapist. So Wilbarger protocol, which gives you deep pressure and proprioceptive technique, works on 4 basic parts. That is brushing externally away from the mouth at the joints with an external brush. You see the Thera brush on the picture there. Then joint compressions, then later coming to the oral stimulation extraorally, intraorally, and finally giving them some sensory diet for all the senses. By sensory diet is basically giving activating or giving stimulus to all your senses, like trampoline for your vestibular system, swinging, and likewise. Another technique which the occupational therapist can be prescribed when you see some oral motor dexterity deficit in your patient would be Beckman orofacial deep tissue release, which uses these 3 instruments and oral facilitation techniques. Now these will help in tactility, stabilization of the jaw muscles, contraction, relaxation, lateral movements of the tongue. Now these are all very important for preventing food pouching or feeding disorders, which in turn might lead to early childhood caries in our children. Now, some of the strengthening, oromotor strengthening exercises, which we could also suggest our patients, would be lateral movement of the tongue, keeping the honey in the corners or corners of the mouth. The parent can mimic this so that the child can, do likewise, or in front of the mirror, puckering, blowing balloons, blowing candles, licking. So all these are motor strengths. Now the sensory awareness by introducing the different senses, touch receptors, food in the tongue. So most of the preemies would not have these maturities, and that is when the whole body later on goes into a global hyposensitive condition. So these needs to be worked upon, not just for neurodiverse kids. This is applicable even for the neurotypical kids. Now, sense enabling toothbrushing without the paste, that is the dry toothbrushing, wherein you can first reach and give them proprioceptor or tactility stimuli so that the child accepts, and this basically reduces the bite reflex and gag reflex, which becomes very challenging for a dentist to render any services to the children. So the parents have to be educated that we need to resolve the bite reflex and gag reflex much early in the infancy or childhood. So the grossiness, the gross of the toothpaste, the slimy effect, the taste, flavor, all this is minus. Only the tactility input is given, and this can be continued even in toddlers on the sick days when the child is not wanting to go to the washroom. So the dry tooth brushing can help in the sick days as well, and this prevents the droplet as well as contact transmission. Now, coming to the sensory sensitive oral hygiene care, which can be implemented at home, encouraging messy play. That is, a child, this is the same system which occupational therapists implement for the child who is having, feeding disorders. Sequentially introduces the sensory approach and then goes to the oral. So you're letting the child play messily in the texture of the food, smell of the food, and taste of the food, color of the food. So the same thing applies to our toothpaste. So sequential oral sensory approach is very important so that the child accepts toothpastes into the mouth and there is no aversion to the oral hygiene practices. So you have dental health sensory play, wherein the child is given, encouraged the teeth boxes so that the child can learn. It becomes a fun play and the child enjoys the oral health care skills. Now moving on to how to train these children for brushing. So toothbrushing itself are typically 15-step tasks. So how are you introducing them? Systemically desensitizing them by using only the front tooth brushing, then familiarizing them and sometimes giving them token. So these are the 4 stages where the assistive toothbrushing is implemented till almost 9 years. And then later the parent gets confident, and only then the parent can move out and allow the child to go for independent toothbrushing. But most often than not, we see the parents giving the independence to the child in toothbrushing as early as 2 or 3 years, and they claim that the oral hygiene is being maintained, leading to early childhood caries again. So positioning of parent-led toothbrushing can be on the floor as a fun activity, increasing the bond between the parent and the child. Here you can use a dry brushing technique at the dining hall, watching TV, or interacting with the family members. And assistive toothbrushing, you have to prevent the biting, you use two toothbrush technique, so that one brush is to open the mouth and start brushing, then hand over hand, this is to guide toothbrushing, prompting and guidance. And also, when the kinetics of toothbrushing are still not developed, the motor dexterity or the fine motors are not developed, we would give them some handles and textured toothbrushes. And these are some patented toothbrushes, polished toothbrushes, Dentrust. The Dentist three-sided toothbrush may be difficult to enter the oral cavity. So I would suggest the 360-degree for the child to play by itself. This would render the required oral physiotherapy or the proprioceptive stimulation the child wants, the tactility, and then it becomes a fun game. Also, video modeling is very important for these neurodiverse kids. They need a video prompting. That is, a step of the toothbrushing technique is shown, stopped, the child is asked to emulate, and then continue. So this is a video prompting chaining, which actually implies the applied behavior analysis. So the other modelings are that they're seeing somebody else modeling it, the technique, which may not be very successful for the patient with neurodiverse condition. And point of view modeling, this is as if the child is seeing how he would see the toothbrush and learn to brush. That is also successful. Now, coming back to external stabilization, so far we have seen the internal stabilization of the oral cavity at home, or even in the dental operatory. You can come to the dentist who's trained, or the occupational therapist, and get these needful done. Coming back to the external, that is the clinic. Here, this almost summarizes the presentation so far. So pre-visit parent consultation, the parent would visit the clinic, see the regular dental setup, would fill the questionnaire form or the sensory profile form, and would highlight which senses. The parent is the first teacher and the home is the first school. So don't underestimate any suggestions given by the parents. Always respect, acknowledge them. And likewise, from the dentist, the child is given some preparatory, parent is given some preparatory stuff for the child. And as well, the dental professionals for the next appointment scheduled for that particular child would do some modifications, minusing or exaggerating one of the stimuli which the child is affected with. And finally, there would be a successful dental appointment. So this is basically to give an emotionally protective environment to the child and sensory safe environment. So this is a chart which shows that you see the first session with regular dental environment, and then finally it is sensory adapted dental environment which gives you the successful treatment. So step by step, how the parents take the homework. Coming to the social story, so they would come take the pictures of the dental clinic to be visited, dentist, the operatory, and they have to exhibit the appropriate behavior the child has to show. This has to be taught. Any personal fears or apprehensions from the parents should be refrained from commenting in front of the child, and they would have to encourage how the child should behave in response to the receptionist or the dental chair placement. So this was introduced by Carol Gray. This is one of the most important methods the neurodiverse kids learn any self-help skills, not just toothbrushing, but going to school, taking bath, and so many other things. So this is Green's, we need to get down to the child's level, understand where they are. So sitting with them at the floor is one of the best gift a parent can give to the child, playing with the child. So why not, before a dental visit, do a planned activity training, mimicking a dental unit setup, and take a stuffed animal, try to emulate a dental procedure, and allow the child to play with the dove, emulating this dental floss, printables of tooth prints wherein you show decay and then erase it and show that how the dentist would clean. So basically you're bonding and letting the child to explore and enjoy the sessions, and this was introduced by Greenspan. Now, finally, coming to the sensory adaptive dental chairs. Now, why do I put this last? Because adapting is very easy. Very often, most of the people have been introducing the adaptation and claim that their clinics are sensory adapted. But where is the point when we do not understand that it is not customized for every patient? So every patient with neurodiverse condition is unique, and you need to customize to render a successful treatment. We cannot, generalize and give the same sensory adapted environment to every neurodiverse child, especially the autism. So once you see one autism child, it is only one child with autism, or only one child with sensory processing disorder. So no two children can be same of same conditions, and even the same child on the spectrum can display different behaviors at different times of the day, and even to different stimulus. So you need to have those plus minuses, and that is where your short sensory profile comes into play. So you know which are the two fluctuating stimuli which can trigger your child, and so then you are handy. So basically sensory adapted dental chairs is removing the harsh stimuli from your, or nullifying the harsh stimuli at your dental sensory rich environment. And this basically works on the perceptual hypersensitivity. So how a child perceives and becomes hypersensitive to the senses like audiovisual or auditory. So what are we doing is snozeline environment is basically partially dimming the operatory area and giving them motion pictures on the ceiling, and the butterfly wrap on the dental chair gives a proprioceptive hug. The child feels stabilized. So likewise the improvement, the sensory adaptations happen. So coming to the first encounter in the dental chair with the child and the dentist is where the child can trust the clinician is the gravitational or the vestibular input. Now we should understand this is one of the first senses which develops in utero as early as 5th week. So this is the sensation. The child would come out in the interact with the environment. As soon as the child is born, the child cries, and the crying is because the vestibular input, the child is seeking the spatial awareness, as well as there is a change in environment. So that is when the child wants to react in the form of crying. So vestibular input, this is the first thing the child learns to play with. The child learns to play with gravity. This is important, one of the important senses which most of the dentists overlook. So we try to change the positioning of the chair without asking the permission or without checking if the child is comfortable. So, and that is where we lose the cooperation of the child in the even before looking into the oral cavity, and we wonder why the child is expressing the flight fear and freeze responses or the autonomic nervous responses. So how do we work on the vestibular input? If we have taken a sensory profile input in the questionnaire, we would know that child doesn't like to play on the swings or afraid of the heights. So we need to send the children before the dental operatory to go get their sensory diets from the occupational therapist. After the therapist session, our appointment with the child would be easy. So helping them walk on these rolling balls, figure of 8 helps bilateral coordination, and walking on the balancing stick can also help. And then eradicate the child putting the foot above the ground on the dental chair itself is a fearful experience for children who do not have the sensory integration for their vestibular input. So do not underestimate this first step in the dental operatory. And coming to the natural lighting, that is the visual. So as long as possible, take a natural light or the indirect sunlight, because I did express that in utero, the human skin, that is the mother's skin, allows the light, and the child sees an illuminated world. So the child is more comfortable with the natural light. And of course, when we have a claustrophobic environment, or if our dental clinics or operatory are closed and we do use lights day in and out, then we'll have to reduce the lighting stimuli. As otherwise we would want to take a natural environment where the child doesn't have to adjust coming to the operatory from outside. So we do see some kind of depressive disorders, and also we of late we have seen in the vocational rehabilitation centers, when the neurodiverse people are undertaking their office works, we give them natural lighting office atmospheres in architecture. So the other checklist visual, we did speak. How do you nullify the visual stimuli? By giving them the glasses or swimwears, so that, and then encouraging them to see the motion picture on the ceiling, reducing the bright light. Of course, your smell and taste perception. Taste is something which you should have given the parent at home to let them taste the different kind of materials you would be using for the procedure, so that the child doesn't overreact or become hypersensitive at the dental operatory during this procedure. Avoid wearing any scents or any strong stimuli of aroma. The next stimuli is your auditory. So now noise cancelling headphones, white noise, background music may or may not be helpful, because this can add to an auditory stimuli to the child. So you have to be careful while using. Tactility, of course, the body wrap, butterfly wrap. Otherwise, if a parent can, stabilize the child with the touch and, hold as a restrainer, that would be more comfortable for the child as per my experience. So that is restraining, which I was talking about. So we do not like restraining, we do not like the child to be clamped down, but we should understand that car seats in a moving vehicle are for a reason. That in a moving car, the child needs safety, so that the child doesn't get hurt, and also depending on their cognitive ability. So I would prefer the parents as the active type restrainers, so the child is in a very comfortable, emotionally secure environment, and also the parent gets the first hand witness of what's going on with their children. Now, as I'm speaking about the parents, I take a very I give very important emphasis on parenting, neurodivergent parenting, because if a pediatric dentist in concern treating the child is not connected or bonded with the parent, then the success of the treatment is very doubtful. So we need to empower these parents, and especially in case of neurodiverse kids who are non-verbal, communication becomes difficult. Only the parent is the best person to express what the child is wanting, seeking, or whether the child is in pain, because in non-verbal children it is very difficult to establish a communication, and there is always a stranger anxiety which our parents can play an important role. So they become a pivotal part of the team for me when we are practicing on neurodivergent kids. Now we should also give them respect and give them high regards, because parenting itself is a very challenging task, and neurodivergent is an additional task. Now their parents, like all parents who are unconditional, selflessly loving their children, but somewhere a neurotypical parent would expect some reward at the end of the once the child grows, or an occasional you're hugging, kissing. But neurodivergent parent, the child may not be comfortable with a cuddle, may not respond to their emotional reciprocations. So that can be very painful, and you need to be in empathetic to the parent, and you should assure them that they're doing the best they can for their child. And also you should be able to encourage and give them courage, rather than wanting to shoo them off. Ask them to express whatever they can. They will have their own fears of having a second child with the same condition, or they would want to give the whole life to this one child. But once the child grows, because as I see in the experience, the child with neurodivergent conditions, as they grow up, the parents have concern that after them, who is the caretaker for these children. So those kind of conflicting emotions are there with these parents. So you need to pay heed, and still take them into confidence, because they will be a very important key pivotal role in, if you're interested in treating neurodiverse kids. Otherwise it's very time consuming. So moving on, as I've already mentioned in the previous slide, that for communication, the parents play a pivotal role, especially in the neurodivergent non-verbal kids. Now, so
Dr.
seeing all
Ghousia, you have asked me. Sorry,
yes,
Dr. Ghousia, you have asked me to remind when it's 5 minutes to
yes,
your end of your presentation. Okay, I'm sorry
yes,
for that.
yes, I'll do that. Yeah. So professional burnout, we see, emotionally. So we are listening so much to the parental grievances and child. So we might get emotionally exhausted. So these are the three conditions we would see mentally and physically. Of course, our postures may be compromised. So we do need to take care of ourselves. Also save ourselves from biting. And the problem with the sensory adaptive conditions or environment is we might not appreciate the separation of the instruments or detachable instruments. So we have to take utmost care of non-detachable instruments. Now, this is a video which I would request Dr. Polixini, if available, I can play. This is simulation, what a child would experience with autism. And this is in study. We would want the healthcare professionals to experience this, then only be empathetic. They can be empathetic, and they can remove the disparities or inequalities in the healthcare professionals. So I would just play, and then Dr. Polixini can stop me. This is how a child in the mall experiences with a neurodiverse condition. And this is simulating our dental clinic, wherein visual stimulation is so high. There are sounds. These are projects which are happening in the other part of the world uh, for allowing the healthcare professionals to experience how a child with neurodiverse conditions sees the world of working school.
Two, 6, 7, 8, 9.
The child is emotionally regulating himself,
Check my
but he
hand.
is not able to help himself. The parent is playing the co-regulator part, whispering sounds, but still doesn't help in the mediation of the senses. Child sensitive storm is exhibited, and then we perceive it as behavior without understanding the
I'm
reasons
not.
behind it. So, what we learn in the student curriculum is that as pediatric dentists, the child should not depart in tears. But I think sometimes we should be human. We should allow ourselves to understand there is a learning curve to manage these children, and sometimes failure, not all the time successful. So, there is a learning curve for the child as well as the practicing practitioner. If you don't love the kids whom you're treating or not love the work what you're doing, then we might not be able to do justice to the work. And this is a scan for the feedback as requested by Dr. Polixen. Yeah, thank you. Thank you for your patient hearing.
Thank you very much, Dr. Begum. I'm really sorry that I had to stop you,
No
but I
problem.
mean,
No
it
problem.
just we're having at 3 o'clock we have clinic, so it was
Yes,
very
I
interesting your
understand.
presentation. I mean, I was really impressed with the exercises that you are asking the children to do and how you are changing the environment. And I don't know if any of our pediatricians would like to say something. I know Dr. Rachapa and Dr. Triveni know you from the
Yeah,
past, so
my
I mean,
seniors, I forgot to acknowledge them. Hi, ma'am. I do see them. It's great to see them. She is my senior from Davangere. Hello, ma'am. Good to see you.
and I would like to say that I will stop now the recording. Okay, thank
Yeah,
you.
I can't hear Triveni, Dr. Triveni. Ma'am is PhD in
Sorry.
pediatric. Yeah, no problem. Hi, ma'am.
Yeah,
Yeah,
hello, Ghousia. I would
yeah,
really
yeah,
like to appreciate the work you have put in. Like I and Rajapa were just discussing, it's
yeah.
truly like when it's special children and when you have dedicated your life for that, it's really, really a commendable job is what you're doing.
I
And
take the note from Dr.
preferring,
Rasa. Yes,
yeah, and preferring the non-pharmacological way because we know as pediatric dentists how difficult it is, especially like now we are here and when we don't know the language, it's very
yes.
challenging
Yeah. And
because
then
without
insurance
communication,
claiming cost factor is also difficult, at least in developing country like ours. So I would like
yeah,
to see Dr. Rachappa if possible. Sir. Yeah.
yeah, yeah, he's
Yeah. Hi, sir. Hi. Hello. All good. Yeah. Thank you, sir. These two are my seniors from the same institution. So, that's what down the practice I did see why our techniques were failing. And then